for an interactive discussion. Hopefully they'll give it some thought. Are you going to sit up here or together up at the lectern? Where are you going to sit? All right. Okay.
We started off by not having any slides, and then we decided 30 minutes to the session might be very long for a network. So we have got 3 slides.
Perfect. Yeah. Good intro, and then.
So we've got two speakers to talk about the structure and function of the new amyloid network. Professor Ashu Wechalakar, who's been the leading hematologist at the NAC for a number of years now, and is an international expert in his field. Guy Pratt, who's been a hematology renaissance man for a number of years, a myeloma expert, lots of clinical research, lots of guidelines, including the MGRS guidelines.
So I've got a few slides just to give you all a background of what this network is all about, and then it's really intended to be interactive because we've never had a network, so we need to learn what a network actually will look like and how we'll live with an amyloid network. So we've been trying for 10 to 12 years to get NHS England to fund a network of centres which would be interested in amyloidosis, have the right support to diagnose and treat these patients. And one of the main reasons why it became really critical that we needed a network is this is the numbers of patients that we are seeing at the NAC. The orange bars are ALs, and as you can see that probably from 2015-16, our total number of AL follow-ups has remained relatively stable. There was a dip around COVID. But these kind of bluish-grayish bars are TTRs. And the number of TTR patients these gray bars, starting from here, have really gone up. And we are now seeing close to 700 TTR patients, new TTR patients a year. So our total patient numbers have massively increased, and even in the last few years, these numbers have gone up. And that has led to an increase in total number of follow-ups. And these are often elderly patients in their 70s, 80s, and 90s. And clearly, we are diagnosing more ALs as a consequence, so the median age of AL patients has also gone up. So it's really critical that we need to be able to see these patients closer to home, diagnose and treat them better. We approached NHS England for a network of 10 centres around the country. NHS England came back and said we would support 4 in the first instance. A call went out for these 4 centres, South West Midlands, North West and Humber, and then North East and Yorkshire. And eventually, we only have got 2 centres which have been funded as of this year by NHS England, which is Birmingham and Liverpool, for these 2 regions as the first 2 network centres. We're hoping that in the next financial year, we will get another call for new centres to come up. I'm just going to skip these 2 slides in the interest of time. So what we thought the centres would work like is that there would still be the NAC, and I'll show you what stuff would be done at the NAC versus what would be done within the network centres. There would be the local referring hospitals, which would refer patients into the local centres, all of the patients that are diagnosed, and I'll show you which ones will go in. We will have an MDT with the network centres, and of course, anybody who wishes to join into this MDT is most welcome to join. And then all of the regions which are not covered by the network centres will still continue to refer patients into the NAC, as has been the practice for many years. Things which will remain at the NAC will be SAP scintigraphy for the time being remains at the NAC. We continue to have the central amyloid typing laboratory for mass spectrometry and proteomics for amyloid typing. And we'll continue to have the National Genomics Service for amyloid genetics, which is funded by NHS Genomics. My next slide. We'll still continue to provide serial monthly free light chain monitoring for all the patients as we normally do. We have been storing serum samples for most of the patients over many years. We'll still continue to provide the serum repository for all patients through the network centres. AL patients, we're doing it every 6 months. In TTR patients, this is being done at 6 to 12 monthly intervals. And we're hoping that NHS England will fund a new mass spectrometry-based measurement for monoclonal proteins this year. And we could provide that as a central hub service for everyone who sends the sample in. What about the network centres? The expectation would be that the initial diagnostic workup could happen there with tissue biopsies, which are done, tested for Congo Reds, then sent across to the NAC for typing. Genetic samples sent across to NAC for typing. All imaging which is not SAP imaging, which is DPD, echo, CMRs, basic cross-sectional imaging for myeloma will be done locally. And then all the standard blood tests which we do for an amyloid patients, biochemistry, biomarkers will also be done at the center. How will the whole follow-up work? I think this is the bit which we kind of need to figure out, and this is starting to become very complicated, and we still don't know exactly how this will work. So the expectation is that newly diagnosed AL patients will come to the NIC for a full assessment because SAP scintigraphy is still useful for newly diagnosed AL patients. Newly diagnosed TTR patients may not need to come to the NIC because they have got a non-diagnostic pathway where the whole diagnosis could be made. And once they are at the MDT, then they go back to the network center, and then they will be followed up through the network center for the AL patients. All of the local centers will refer to NIC and then MDT to the network center, and then follow-up will continue via the network center rather than via NIC. There will be MDTs, there'll be follow-up of face-to-face visits between the patients to the network center, and then Guy can tell you what the vision is of how frequently these patients will be seen locally. AL patients will still come to the NIC for a face-to-face SAP every 3-4 years, 2 years, depending on when we decide the frequency is appropriate for these patients. There are patients with rarer amyloid types who will still continue to be followed up at the NIC. And then we have got the complex localized patients where we've developed a localized clinic at UCLH, and we do see quite a lot of these patients at UCLH. And we'll still continue to see some of these patients at UCLH, though potentially a number of these patients could then be transitioned across to the network centers. I think that's my last slide. Over to you, Guy.
It's time for questions, I think, really.
Charlotte.
Yes.
3 as well. One more chair, please. Yeah. So, Guy, maybe you could give us your thoughts about how you're setting up as a network center, and then we'll invite questions from both online as well as from the audience here on all of the talks.
Well, I represent the Midlands region, so I think that's important to say that we won't be taking anywhere north of Watford. I think one of the really important things we'll do is we'll have an MDT with the NAC probably on a Friday morning every 2 weeks, and that's for everyone who's got a patient can join that. It's really advice and guidance I think is critical here because we don't have capacity for seeing millions of new patients. So I think that's probably one of the most valuable things because it may be you just need that advice before doing anything. As Ashu said, new patients still should go to the NAC. It's really critical that tissue goes at the same time because obviously amyloid is a diagnosis that's made by a mass spectrometry a lot of the time. And we will follow patients up, so that's our role, and I think it's really important to use this mainly for advice and guidance. It's really important that we have the right access to results and can see what's happening to patients, and that's, I think, going to be quite challenging with the NHS we've got. We can't see results from down the road, so I don't know how it's going to work, but we need to have that in place as well. I think we'll aim to start at the beginning of January. I think that's most likely. And I think that's about it. So I think this is really for you guys to ask questions more than anything.
Hello, excellent presentations. I'm Theodora from St. George's, Fenella sitting next to me, and we've got a common question for Dr. Manistri. It's about how cardiac amyloid patients. So we recently have had, well, relatively recent, quite a few deaths in the community of patients who are on treatment with fantastic responses on the light chains in terms of their AL amyloid. And we just wonder, I understand that having defibrillators hasn't showed any clinical benefit, but there should be cases that should be considered. Do we have any guidance? Because we've all felt, being non-cardiologists, that maybe we wouldn't have lost these patients if they had ICDs in place.
So I think it's a really important question. So the only data, or the only strong data that's out there was a small study from the NAC where they put loop recorders into 20 patients to see what happened to those patients in terms of rhythm. And what they found is that the majority of patients who died ended up dying from a PEA arrest rather than a VT or VF type arrest. And therefore, it's unlikely that having had an ICD put in would have changed outcome in those patients. We have had a couple of patients who we've put ICDs in when we were going to put pacemakers in otherwise. We had one patient who had a arrest prior to, they were admitted with an arrest and were found to then have amyloid. And then we ummed and ahed as to whether we should be putting a device in this patient simply because their prognosis was probably going to be quite poor. But we spent a long time thinking about it, deliberating of it, and did put an ICD in. And actually that patient then went on and did extremely well, kind of unfortunately subsequently died from something completely unrelated about 3 years down the line.
I mean, we follow these patients extremely closely because we've got obviously a fantastic heart failure team. So Lisa Anderson leads them. And every patient, you know, is monitored, and we have a, you know, MDT post any sort of sudden death to look at really, is there any triggers that, or anything that we could have done that would have changed that pathway. And actually, to be fair, we're struggling to see any sort of clear trigger that might have changed if we had put an ICD in, if we had given any other antiarrhythmic drug or anything. So they are inquired. It's just really hard when you have a number of patients in a row have a sudden cardiac death. I have to say though, most of our patients are extremely advanced cardiac amyloid patients, so I think that's one of the issues.
I mean, the only other thing, Ashu might want to comment as well, the only other thing is amiodarone, which I know that you give a lot of your patients. We give quite a lot of our patients. We have had some issues with long QT in those patients though as well. And also if patients have got pre-existing conduction abnormalities and haven't got a pacemaker in, if you then give them amiodarone on top, that can make that worse. So you are in a difficult place. We are quite fastidious about making sure we've got the monitoring done before we start treatment. We then start the treat patients with inpatient monitoring for the higher risk patients. And we end up putting pacemakers in prophylactically in patients who have got significant conduction abnormalities on Holter monitoring before starting treatment. But we still have, you know, difficult outcomes as well. Ashu, I don't know whether you want to comment on as well.
No, I mean, I had an email from you about this, and I was thinking about it, and I didn't really have a good reply, which is why I haven't replied. We still see these sudden deaths. Having a run of 4 is unusual, but I mean, it's very hard in these very advanced patients to know why, and sometimes it's just very unfortunate they were together. And I mean, Lisa Anderson provides a great service for you, and you've actually got a really excellent cardiology service that looks after these patients. So telling you that optimize all of the other stuff is really not the reason for the deaths. Once in a while, we've had patients who've had a really good response. And again, this is not 4 in a row, but once in a while, patients actually respond, get really well, they feel really well, and they start pushing themselves too hard. They get hypotensive, and then they underperfuse, and then suddenly start having a major collapse and die afterwards. So we've had once in a while an occasional patient where the death has been because they've had their DEX on the day of the DARA, they've actually felt better because their heart has improved. They've gone home and cleaned their entire attic, which is exactly what one of our patients did, came down, felt unwell, collapsed, had a VF and died. So we do have this once in a while where patients will do something different, or their blood pressure was not optimized, or their magnesium was very low. So one few unusual things to kind of look out and make sure that we've done the magnesium, hasn't gone off on the diuretics, make sure the blood pressure has been good enough. But I think in terms of proactively, as Charlotte said, most of these are EMD type arrests. They are not VF arrests. And even amiodarone is not going to change that. And if anything, amiodarone patients become bradycardic and are more likely to get an EMD arrest. And I think we use amiodarone, but we use it with super careful monitoring. We get them to check their heart rates. We stop it if the heart rate starts to drop, even clinically, irrespective of the QT. So it's a hard one. I don't think we have an easy answer to that.
I just wanted to add one tiny plea. Discussing resuscitation and ceilings of care, I think, is really important in these patients. And that's one of the things, actually, we discuss really early on. I think it's important to involve the family in those discussions because sometimes patients can be diagnosed at a very late stage. You're starting treatment and they think everything's going to get better. So it's important that people's expectations around prognosis is clear to both the patient and their carers.
Yeah, don't worry, I think we were aware of that. We've got another case of, actually, I don't know if it's all right to just ask, it's a renal case.
Yeah, it's a renal case, so we're going to the second talk. We actually have a smoldering myeloma patient who hasn't needed treatment, but he's had end-stage kidney disease, and he was eventually biopsied. So the question was that he has, I'm going to read this now, a fibrillary glomerulonephritis. And the nephrologists were wondering whether this could be associated with his smoldering myeloma or not, because apparently this is very rare in myeloma. Unfortunately, he's end stage anyway, so I suspect if it's related, treatment would only be, it will have a point if he would go for a renal transplant. So that's where we are. I just wanted to ask your opinion.
So that's where the DNA JB9 stain comes in as completely key. So effectively, if that stain is negative, then that probably was related to the clone. Whereas if you've got a positive DNA JB9 stain, so it's a specialist type of stain. So in fibrillary GN, when they did proteomics on the fibrils, they found this particular protein called DNA JB9, and you can stain for it effectively. So if you have somebody with fibrillary GN who's DNA JB9 positive, no clone, you're kind of away, and it's nothing to do with kind of the bone marrow. But if you've got a low-level clone and you're DNA JB9 positive, then you're probably not related to the clone. So that's the stain that you kind of need to have. And if where's your unit?
We're in St. George's.
Okay, so they may do it, and if they don't, then send it to Candice at the Hammersmith.
To where, sorry?
Candice is the histopathologist at the Hammersmith, and she will do you a DNA JB9 stain.
Thank you.
Thank you. This is, I guess, mainly addressed to the new amyloid network centres. Do you think there's a risk that a large number of patients who historically have been treated at DGHs 15, 30 miles away from your centre will now choose to have all of their follow-up in these network centres going forward?
I really hope not, because I am the amyloid haematologist, so we wouldn't be able to cope with that. I think it's got to be sensible, hasn't it? It's got to be more, I think, about advice and guidance, and not just seeing the patient for absolutely no reason whatsoever. So there's critical time points in amyloid, I think, particularly after induction therapy, if people aren't responding to treatment or that initial phase of treatment. That's where the MDT would be extremely useful. But we will be doing follow-up like the NAC, which is usually annually, isn't it, or occasionally 6 monthly. So that will happen. But we don't have capacity. We're not funded to the same extent as the NAC. It's Jenny, myself, and Will. And we don't have SAP scans, for example. It may be that's very important. So that's something to be thinking about.
Yeah, no, it's very. I mean, I work in Newcastle, and we've got a large number of DGHs sort of within, a 30-mile radius of ourselves who have been, treating amyloid patients for many years, and our concern has always been that, they will choose to rather than being followed up in 2 or 3 centres, I'll just think, oh, actually, you know what, I can just drive an extra 20 minutes and I'll have all my treatments, I'll see my cardiologist, I'll see everyone, with yourselves in Newcastle. But it's just going to be a way of trying to, prevent that from happening and keeping that MDT network really open and functional.
I mean, this is the intention is that it will replace their NAC visit rather than become a treatment center. That was the intention. And I guess we'll all have to learn how we live with this new network. But I'm sure there will be these challenges, and patients will want to stay. So it's not an enviable task, because we've now generated a list of patients we want to give over to you from the NAC. So we'll hopefully have that list ready in the next 6 weeks.
I think maybe I'm being really naive, but you guys as haematologists follow your patients up methodically very frequently, because you have to, and you've built really good relationships with the patients, and I think you've got a lot of trust with your patients, and I'm not sure that they will all suddenly want to jump to be followed up by somebody that's met them at the end of their therapy and met them kind of once. So And actually you tend to find that you will want to kind of hold on to your AL patients and kind of look after them. Even within our centre, each haematologist doesn't want to give up their AL patients. So I'm less worried about that, but maybe in a year's time, I might say something different.
Got a question from online, specifically cardiology, which you've partly alluded to. So do you use inpatient telemetry to start treatment? You said you had, you based it on sort of risk stratification based on their 24-hour tape, but how do you stratify that? So if they get two little broad complexes, is that enough to bring them in? How long do you monitor them for? And if they're on amiodarone, for example, how long do you leave them in amiodarone for?
Yeah, so there's no kind of fixed risk stratification that we use. It is slightly on a patient-by-patient basis. If you've got a patient who's already got fluid overload and who may benefit from intravenous diuretics as well, then that gives you a good opportunity to be able to bring them in, diuresis them and start treatment. If patients have had any salvos of ventricular beats, then we probably want to bring them in and monitor them. Patients who have got pre-existing conduction abnormalities, we probably want to put the pacemaker in at the same visit as well. So we do it all kind of on a patient-by-patient basis to a certain extent, and some of it's going to be based on frailty, renal function, etc. as well.
And salvos of wide complexes, is that an indication for amiodarone in your...
Yeah, I would start amiodarone in those patients.
And then you stop it when? When they stop treatment or when they stop bortezomib, which is thought to be a culprit, although I'm a bit...
So again, it's this. I'm afraid I haven't got any hard and fast answers. Some of it's also dependent on whether they develop toxicity as well. The number of patients that then develop thyroid abnormalities and things related to the amiodarone. So you are creating other problems by starting them on the amiodarone. I don't, again, Ash, you know whether you want to jump in and add anything.
No, I mean, there isn't a hard and fast rule on the amiodarone. We definitely would give it for the first 4 months without any doubt, but then usually case-by-case basis, we start withdrawing. But we almost always do a halter before we change. So we usually do a step down. So we normally go from 200 to 100, step down, and then by 6 months, the aim is to come for patients to be off the amiodarone. The only ones we leave on are the ones whose NT-proBNP is 25,000 at 6 months. And those patients, we're just too scared to withdraw because we think they might die on the withdrawal, and we've certainly had some sudden deaths which may not be VT related. So it's very individualized. And we admit far less patients because I work at UCH and we have got no way of monitoring these patients, apart from sending them over to you because we've got no monitored beds in the entire hospital, apart from AMU. So we...
intensive care?
Intensive care, it's...
That's where we have to admit our patients.
It's a very tricky one to get them in and out of intensive care. So we have therefore developed a pathway of having a Holter monitor before. We use blood pressure and what supportive care the patient has at home in terms of monitoring their blood pressure and everything else. If they can, they are very well supported. They very well understand how to monitor their diuretics, their midodrine, their blood pressure. We would then treat them on an outpatient basis. But on the other hand, if they're elderly, they're frail, we are really concerned about their fluid retention, we bring them in.
Can I ask a follow-up question? Shri, you presented data on belantamab mafodotin. So I've got similar problems. I've got a patient on amiodarone, belantamab mafodotin, and hepatotoxicity. Have you had these issues, and how do you manage amiodarone in that situation?
No idea, to be honest.
Good answer.
No idea how to do it. I mean, so I have to echo what Ashu says. Normally, generally, I would aim to stop the amiodarone by 6 months. Now, whether the amiodarone and the belantamab are both contributing to the keratotoxicity is anybody's guess. So I suppose, if I had to stop, I would stop the amiodarone and not the belantamab.
So the one thing that's really toxic is intravenous amiodarone. All the patients we brought into intensive care and then they've been for a semi-emergency and loaded up on intravenous amiodarone, every single one has had severe liver toxicity. So
yeah, we don't load anyone these days because we found that when we started loading these patients, they all ended up in BARTs very quickly needing a pacemaker. So what we've kind of adopted is we often do maybe 1 day of 2 days of 3 times a day, and then we just do 200 milligrams daily very quickly with a very abbreviated loading schedule. And we have a pulse rate threshold of 70. So anyone whose pulse rate comes close to 70 or drops at 70, we stop the amiodarone until the pulse rate goes back above 70. So we use the pulse rate as a guide to amiodarone even during loading or during therapy. And all the patients are told to call us if their pulse rate drops below 70 once from treatment.
I've got a question on the... Oh, sorry, the question over here.
Thanks. So just back to the network itself, perhaps for Guy and for Ashu. So you alluded, Guy, to sort of access to results and so on. One of the big advantages of having a national amyloidase centre over the years has been the quality of the data, some of which we've seen today, and obviously the databases that you hold at the NAC. Are NHS England supporting rollout of the data platform that you have to be able to record that data in Birmingham and Liverpool?
So I can take that question. So NHS England have given us money to create a new database which will be potentially accessible from outside of the Royal Free. And the database will then be directly linked to every network centre's own data, so that all of the data that we're collecting now at the NAC will still come into their database, which will be, I don't know where it'll be housed, whether it's a cloud-based or whether it's Royal Free-based. And every center will be able to access the full data of their own patients remotely at any time. And as we roll out more centers, it's possible we might be able to open up this database, or we're not allowed to call it a database any longer. We have to call it DPMS is what we meant to call it, Digital Patient Management System, because databases puts it into a very different department of NHS England, which is quite different to DPMS. So we are hopefully going to get this. I just don't know how long it'll take because of the digital safeguards that are required for this thing, but there is money there that has come through specifically for developing this, and the scoping exercise has been completed. We've identified a couple of vendors. We kind of know what we want in it, and we sort of know what data needs to go in it. Guy and Stephen Hawking and the team at Liverpool also aware of what data is. And at least in the short term, we are thinking we'll go the old-fashioned way of Excel spreadsheets for getting the data in, which is how we used to do it until about 3-4 years ago. And then when this comes online, it'll become much more easy.
There's a question online. I think this is probably best for you, Ashu, regarding doxycycline. There was, we used to recommend it a lot for there's a talk of it potentially being anti-amyloidogenic, especially in the cardiac situation. And I think the data kind of showed that probably wasn't the case, but certainly every patient I have going through the NAC, it's still recommended to start it in every single patient. So why is that?
So it's the data is very mixed in the sense that the in vitro data of doxycycline stopping amyloid fibril formation in AL is actually very strong. The in vivo data is really very mixed because the only study which looked at cardiac amyloid was the one that we published, but that was a single center study, so it's extremely biased. Then there was a Chinese phase 3 study where patients with all kinds of stages were treated with doxycycline, which was the negative study, which is really where it was negative. And then there was a Mayo Clinic auto-transplant study where patients really did not have cardiac amyloid. The other important thing to remember is that it's a tetracycline, so it's very calcium-seeking. And the calcium content in the heart is much more than everywhere else. So the doxycycline levels in the myocardium tend to be about 2 to 3 times the serum levels of doxycycline. So it only works in cardiac amyloid. It doesn't really work outside of the heart if you were to use it. We still give it because we don't know whether a reduction in infections or a reduction in amyloid fibril formation is helpful. But with all of the data that has come out, we have a really low threshold for stopping it. So if any patient doesn't tolerate it, they get really nauseous or they get phototoxicity or something else, we'll just simply stop it. Whereas in the past, we would really try and encourage them to take it with everything. Now our goal is we give it, but we stop it at a very, very low threshold. So that's sort of our thing. I don't think there would ever be a doxycycline study in amyloidosis, but hopefully with the better therapies, and once their light chains are normalized, the role for doxycycline is probably very minimal. So it's probably most useful when they still have persistent light chains in the first 3 to 4 months till they get into a CR. But this is completely data-free given where everything is.
Yeah, I quite like them being on an antibiotic, and you might as well give them that as anything else.
Yeah.
Can I ask one question? Could be a wrong question. It just popped in my mind. Before DARA VCD, we used to struggle for second-line treatment in primary amyloidosis. But now, how do we bypass the blue tech criteria?
Next question.
I think Sri is the expert. He's talking about amyloid treatment.
It depends. Well, I mean, it's very difficult to bypass the blue tech criteria, so I don't know how to answer this question. I mean, I suppose it depends on how much you can convince your pharmacy and how much pushback you get from the pharmacy. That's where I would leave it. I mean, I can't say you bypass the blue tick criteria in a
I
forum
think
like
my
this.
argument only is what is primary amyloidosis? So how do you define primary amyloidosis? Basis that you can figure out there is no definition anywhere which calls what is primary and what's secondary amyloidosis. So if you call it that it's not primary, it's secondary to myeloma, you can bypass the blue tick criteria.
The other thing is that to highlight the diagnostics, it's really important to make sure all these patients have 10% plasma cells when you work them up. So when I report these out through the SHMDS, they've always got 10% plasma cells on the nose.
Agree.
Thank you. I think we're grinding to a close, so I'm going to close this session. Before I close today's session, I do want to give a shout out to Jonathan Siv, who's led the educational part of the UKMS for the last 2 to 3 years, maybe. And it's a testimonial with so many people here today is because Jonathan has led a very feedback-led, clinically focused, and very keen on getting diverse set of speakers kind of come in. So we should thank Jonathan for all the efforts that he has done in putting these meetings together. You will all get a participation certificate plus a feedback form. Feedback is critically important. We do want to ensure that the right set of sessions are being presented in these national meetings with, increasing number of folks kind of coming through. So please do give us your feedback. The next key day is the Spring Day, which is going to be chaired by Tracy Chan and Chris Parrish. It's called the Holistic Approach to Plasma Cell Disorders. So mark your diary. It's the 19th of March, 2026 for this event, and it'll be held here. I want to thank my co-chair, Kevin, for doing this session with me together, and Charlotte, who was here early with me. Thank you all for attending, and thank you to our online attendees as well, and have a good evening.
Very good.
Well done.